everyone, a very good day to all of you. So this video is basically regarding back to basic series based on the module management of delivery. All right, so management of delivery is actually again a very short module in which you need to be clear with your applied clinical knowledge part. That is, you need to be very have a concept of what all the guidelines say, and also at the same time you need to be very good in your communication skills, because here patient might have her own list of wishes. She may have her own opinion about something related to delivery at a particular place in a particular scenario, but you have to convince her regarding the safest option. So only two things, if you are good at it, and you will easily pass this module. So as usual, let's start with the quote that concentrate all your thoughts upon the work in hand. Okay, so the sun's rays do not burn until they are brought into a focus. So right now, hope all your practice towards cracking your MRCOG part 3 is going fine. So do concentrate on practicing your tasks daily and practice with your role player so that you can get a feel of how the things will be actually in the exams. And focus, always try to practice daily. Now, in management of delivery module, what cases to expect? See, there is labor module and there is delivery module. So in management of delivery, you will basically get like patient may not be in immediate labor right now, but she has come to discuss her delivery plan. And in labor module, you get patient who is already in labor or labor ward prioritization. So those patients who have come to you for discussion of their delivery plan will mostly be in their third trimester. And usually they give such cases in which there is some complication. Like suppose she may be preterm or PPROM may be there. Again, the case may be either a simulated patient task or a structured discussion. So you need to read very clearly that what it is about. Then she might be a twin pregnancy and she may be insisting for home birth. She might be a breech pregnancy. In breech, she may be frank breech or footling breech, and she may be here to discuss about her birth options. Usually she will insist on unsafe one and you have to convince her for the safe option. Then she might have suffered from shoulder dystocia in her previous delivery, and now she's anxious to know like how she can deliver. She might be wishing to deliver at home, but she may be anxious that I might be at risk of shoulder dystocia again. So how to go about? Or she might have incurred a 3rd degree or 4th degree perineal tear in her previous pregnancy, and now she has come here to discuss about her birth options. Then maternal collapse. This you might consider in maternal medicine module also, or in early labor or in last portion of a pregnancy, she might be having collapse. So usually collapse stations will be a structured discussion. Then previous cesarean, either previous 1 cesarean or 2 cesarean, she might be insisting for home birth. And you have to counsel her regarding the safe options. And the baby may be macrosomic, or she is requesting for induction of labor, but either the time is not right or the indication is not right. So you have to counsel again. Then obesity and she's request for home birth. She might be having morbid obesity and it's not safe for her to deliver at home. So these kind of stations you may get in management of delivery module. Often they might give you a wish list. Like patient has got a specific list of wishes, like she wants to be she wants to be in the comfort of her room with her husband, and she might be wishing that candles should be there and music should be there and nobody else should be there, and no monitors to be attached. So these kind of list may be there and you have to tackle. You have to go to each and every point and look that whether it is safe for her to undergo that or not. So stations like these will be there in management of delivery module. Now, this slide basically tells us the approach to domains. Information gathering, you have to always look very carefully in the candidate instructions, whether you are being marked in information gathering or not. Sometimes you may be marked where you have to obtain a crisp and relevant history. Even if you are not being marked, you can't skip history on the whole. But yes, then if you are not being marked on information gathering, the history needs to be shorter as compared to when you are being marked. So obtain a crisp and relevant history. You have not to forget the important things like obstetric history is very important. In previous pregnancies, what was her mode of delivery, whether she has had any complications or not, and including future pregnancy plans. Future pregnancy plans is very, very important. Don't forget it. Okay. Then to establish a rapport and to know her present pregnancy status, you need to ask her how has the pregnancy been so far, whether the baby is moving, whether she has named her baby, and things like these are important, not to be missed. And what you can miss is smears, STIs, whether you have had contraception earlier or not. So these things are right now when she's sitting at 34, 36 weeks with you, and she's here to discuss delivery plans. Smears, STIs, contraception, they don't hold much importance. Contraception for future pregnancy might be a thing. To avoid future pregnancy might be a thing, but contraception, whatever she has practiced up till now, might not be that important. Then mention appropriate examination. Appropriate examination will be like, if it is significant, then only you have to examine. Otherwise, you have to just look at the findings. Then obtain information from the GP letter. In information gathering, not only asking history is important, but also they mark you on how you interpret the information which is already being given to you in candidate instructions. So you have to interpret the information from the GP letter well, as well as you have to interpret the investigations well. And then you have to go on to explain. Like communication with patient and relatives is the next very, very important domain in which you are being marked. So you have to first greet and introduce yourself to the patient. This should be in a smiling mode, and if suppose some bad scenario is there, then of course you have to maintain a neutral expression. Otherwise, go with a proper smile. Address any immediate pain or any treatable problems first before starting to talk. Suppose she is having pain or vomiting or any acute problem is there, first administer medications for the same, or ask your staff to administer medications for the same. Take permission whether she is comfortable to talk or not, and then only proceed. Then comes your attitude towards her opinion, which should always be non-judgmental. Whatever the patient wishes, it might be very irrational wish, but you don't have to blame her for having that wish. So you have to be non-judgmental, you have to respect patient's wishes. Just the thing is that you have to communicate what is best and safe option for her, and then go on. You don't have to judge that whatever your opinion or whatever role player's opinion is, that is bad, no, this should not happen. So you have to keep a neutral, neutral attitude towards her opinion, and you go on to present your opinion. You have to be empathetic for her. If suppose she tells that her previous experience was not good regarding the place of delivery, regarding the mode of delivery, then you have to be empathetic that we are sorry that you had such an experience and we will try our best that this time it doesn't happen again. Communicate honestly and clearly about the reports with the patient and attendant. Whatever it is, like she's breech or she's twins, she might be at very high risk, placenta previa, or whatever thing it is, that you have to tell in very clear and honest words that report shows this, and in cases like this, it is recommended to undergo such mode of delivery. So always communicate in patient-friendly language. You have to avoid medical jargons. Adequate pauses should be given, and keep on asking concerns. Don't just look at the time and keep on speaking that I have to complete whatever is going on in my mind. No, always try to encourage questions from the role player, because questions from your role player will fetch you more marks. So always give adequate pauses. Give information in small chunks, so that it is very easy for the role player to understand, and keep on encouraging questions. Also, with appropriate reason, you have to give information. Like if you are giving information regarding VBAC, then you have to be very honest regarding all the complications which can occur. If she delivers at home, what complications or what will be implications of scar rupture, what implications will be of PPH, of scar rupture, what will be the consequences on mother and baby. So all this you need to communicate clearly to the patient without scaring, but at the same time, honestly, it should go to the patient. Don't think that she will get scared. You have to say it to the patient. Then comes communication with colleagues, which is often marked in structured discussion cases. So in communication with colleagues, in whatever way you communicate with the examiner, you are being marked on that. And then in whatever way you are involving MDT, it is very important to involve multidisciplinary team here in delivery module. You can't avoid anesthetist, you can't avoid pediatrician. If she's a case of maternal medicine, also suppose sometimes they give mixed bag. She might be a case of anything like thalassemia or sickle cell anemia or cardiac disease or anything, then you need to involve specialist doctor as well as midwife. So always understand your limitations as an ST5 and involve consultant wherever required, involve MDT wherever required. That will gain you marks in communication with colleagues also and patient safety also. Then come the two most important modules, domains, that is the patient safety and applied clinical knowledge. So in patient safety, it is important to confirm patient's identity and age, name and age, obviously. It is very obvious that we will do that. But yes, it holds importance in patient safety domain. You have to inquire about allergy in any scenario, whether it is SPD or SD. Inquiring about allergy is must. Then you have to identify the reports correctly. Just pay attention to the type of twin which is mentioned, to the type of breach which is mentioned. What was, if suppose in candidate instructions, you are being given that whatever she has undergone in previous pregnancy or previous delivery, just identify it correctly. And in your mind, just frame the consequences which can happen in this pregnancy. And explain the appropriate management according to that. Always, whenever you are discussing about delivery in this present pregnancy, divide it into mode, time, and place. Okay. You have to emphasize on the mode of delivery, when is the best time to deliver, and the best place to deliver. Usually, you will have to encourage her to deliver in consultant-led unit. Mostly, you will get cases where you have to convince her to deliver in CLU. So in that situation, first confirm the name, age, and NHS number on report and go on to explain whatever is given in reports and then counsel her accordingly. Then recognize and communicate the possible consequences of a particular decision on mother and child health. Whenever she has got her own wishes, say that yes, definitely your wish is very genuine, and usually it is very friendly, and to deliver at a friendly and familiar place like home is usually very good. It has got its own benefits, but and then go on to explain the consequences. Suppose in case scar ruptures, or in case head is stuck, or in case in twin pregnancy, some intervention is required after delivery of first twin. So in cases like these, there may be a problem. We can't monitor the baby at home. We can't, doctor is not there for doing any intervention in case it is required. So you have to explain the consequences of that decision of delivering at home birth on mother and child health. And whatever happens, suppose you are telling and she's not agreeing. So at any point of time, you don't have to agree for unsafe option. You don't have to say that, okay, then it's fine that you deliver at home. You don't have to say this. If it is risky for her, don't agree. If she's adamant, put in touch with consultant. Say we respect your wishes, but for the benefit of your health and child health, I will put you in touch with consultant. Don't ever agree that it's okay, you can deliver at home for a VBAC or for twins or for breech or for previous OSE or shoulder dystocia. Okay? So it's your job to not get convinced by the patient. Your job is to convince the patient. Then comes applied clinical knowledge. For applied clinical knowledge, you have to ask relevant history questions, interpret the report correctly, understand the implications, explain the correct management plan, You should know all the options. Like in breech, you should know that you have to offer ECV or vaginal breech birth or cesarean section. So things should be clear in your mind, clear cut, that I have to speak under these headings. Safer ones you have to explain first. The safer option you have to elaborate. The unsafe ones keep at last. Give pros and cons of both. Safer option also, unsafe option also. But keep on emphasizing at all times on the safer option. So it's very essential to go through just brush through the guidelines. I know all of you must have marked the guidelines while you were preparing for your part 2. So it's important and it's time to just brush through them once. They would definitely come to use, whether it is structured discussion or it is simulated patient task. So just a few things regarding do's and don'ts regarding some important tasks. Like first, if we look at do's of preterm or prom. So offer pain relief first before starting to discuss. Often in preterm labor pains or pre-prom, not in pre-prom, usually in preterm labor pains, she's in pain. So offer pain relief first. Offer her, address her whatever symptoms are going on first before you take permission to proceed. Ask how the baby is moving. Don't forget obstetric history, including future pregnancy plans. And also ask how this pregnancy has been so far. Initiate appropriate examination and investigations, whatever is given, go with that, or mention those which are not given. Then you have to go on to explain the condition, what implications it holds, and go on to explain what medications will be required in this, whether it is steroid, whether it is tocolysis, whether it is antibiotic, whether it is Maxil. You have to go on to explain each one by one, that what benefit it offers, as well as how the monitoring of mother and baby will be carried out. Then in don'ts, if patient is in need of urgent care, like if she's in severe pain, don't start taking elaborate history. I'm telling you again and again. Don't forget to talk about antibiotics and steroid coverage in preterm patient. Don't forget chorioamnionitis. Keep chorioamnionitis in your mind, and you have to tell her about warning signs of chorioamnionitis, like if she develops sudden lower abdominal pain, baby is not moving, foul-smelling discharge, fever, then she has to rush immediately to hospital. Or if such things happen and she's already admitted, tell that then we will have to expedite your delivery. Don't give Maxil if delivery is not impending in 24 hours. And don't give tocolysis and APH. So these are few things which you will remember when you go through the guideline. Then comes twin birthing options. Again, whenever any birthing option is there, breech birthing option, twin birthing option, these things remain the same. The do's will remain the same. You have to start by exploring her main concerns. Always throw an open question that may I know what are your delivery wishes? Where and how she wishes to deliver. Just first listen to her first, so that you can accurately go on to address her wishes. Then take a brief and targeted history, how pregnancies of our movements. At all times, reassure her that her decision will be respected and supported, so that she stays calm, and at the same time, slowly try to convince her for the safer option. But if you see the don'ts, always it again stays the same. You don't have to impose your safer option on her. Don't say that, no, you can't undergo that. You will have to undergo that. You will have to, or you have to should not be the word. It would be better if you, try to convince her. Don't forget to tell benefits and risks of both home birth and hospital birth. Tell benefits of home birth also, but so much elaborate on the risks that she gets convinced. Don't forget to brush through the guideline, explain mode, time, and place of delivery. In twins, time of delivery is also important. Mode is also important, and place will obviously be consulted lead unit. And need of CTG, you have to say whether continuous monitoring is required or not. Then comes breech. Again, it's the same thing. Go on to explore her main concerns and convince her, keep her convinced that her wishes will be respected at all times, but at the same time, convince her for safer option. Here, you don't have to forget to tell the benefits and risks of ECB, vaginal breech birth, as well as C-section. Emphasize her to deliver at hospital. Then comes VBAC. Again, ask why she wishes, always explore why. Means if she says that I wish to deliver at home, just try to explore that why she wishes to deliver at home. Maybe she hasn't had a very good experience at hospital in her previous delivery. So always ask why, what happened in her previous pregnancy that she is so displeased. Again, reassure, keep on reassuring, and explain life threats like scar rupture. Don't miss to explain that this complication is life-threatening for both you and baby. If you will say life-threatening, she may get easily convinced. Then again, in don'ts, never impose your safer option. Don't forget to tell benefits and risks of home and hospital birth, and explain mode, time, and place of delivery. If she has got a wish list with her, take up all the wish list points one by one and address. And try to fulfill whatever can be done safely. Listening to music and having attendant, her partner with her at all times, all these things can be easily taken up at hospital also. So say that, yes, these things we will try to fulfill in hospital. We will try to keep your privacy. We will try not to intervene unless and until it is urgently needed, unless and until it is very much needed. We will try to keep the intervention at the lowest possible, in the lowest possible level. But at least we will be ready with the blood. We will be, the doctor will be ready. We will be having a telemonitoring kind of thing so that at all times the wires are not there all around you. And regarding water birth, you have to address, if in case it is possible for her, then only allow water birth. Otherwise, tell the cons. And from your side, you should say that if it is safe or not safe for her. Then suppose if she is requesting for induction at a very early gestational age, like she's 37, 38 weeks, and she's saying that please induce me. So explore her main concerns, why she wants induction, whether any problems are going on at present, previous obstetric history, and then explain her all the options. Tell all the induction methods, whatever will be done depending on the bishops, pros and cons, and also tell the option of waiting for spontaneous labor or at last cesarean section. So your job is to discuss all the options, but don't yield to her request if it isn't safe to induce yet. Suppose she insists, keep on insisting, no. Don't say that, okay, then we will induce you. You have to put her in touch with consultant. If in case it's not safe for her to be induced, either because of her gestational age or because of her any risk factor. So in general, if we look at the template, you have to introduce, confirm the purpose of your meeting, and set the agenda. Explore her concerns first. Throw an open question and ask her to tell out all her wishes. Ask about her present pregnancy, how so far, what about the reports, have you named your baby, is he or she kicking well, what about past pregnancy, whether there was any complication, what was the mode of delivery, whether baby was fine or not, and also future pregnancy plans. Then go on to ask about medical history, surgical history, family history, allergies, BMI, occupation support, mental health, then how far she lives from hospital. This may be a relevant question in this scenario. Review investigations or arrange investigations more if required. Then come to explanation part. First, listen to her story, express empathy that I'm sorry that you had such an experience in your previous pregnancy, but, and then go on to explain. Like your report shows this and this. In cases like this, although vaginal delivery or delivery at home had got this benefits, but then go on to elaborate the risks so that the risks are elaborated in home birth, both to mom and baby, and then explain the benefits of hospital-led birth, or if cesarean section, like in breech, if it is cesarean is more safe, so explain the risks and benefits of C-section then. No need to decide right now. Always give her adequate time to decide. Discuss with her partner or discuss with her mother or parents or whatever, whomever she's living with, and then come back. If she is insistent on her decision that no, I have to undergo home birth, then just put in touch with consultant and close with your action. So just for your review, in UK, there are 4 types of birthing options. She may be delivering at home, supported by community midwife. If she wants to deliver at home, and she is very insistent, then at least you can tell her to deliver in alongside midwifery unit also. Like suppose VBAC, she wishes to undergo VBAC at home. Tell her the option of alongside midwifery unit also, but it's best that she delivers in hospital supported by doctor and midwife, because options like continuous CTG and these things are not available anywhere except hospital setting. So it's best that she delivers at hospital setting. Give her the option of all these four, that it is possible for her to deliver at home, standalone, or alongside unit. But for her, the woman in her situation, it's best to deliver in a hospital where she can be supported at all times by doctor and midwife whenever it is needed. So important basic guidelines which you have to just rush through are ECD and breech delivery GTG, third and fourth degree perineal tear GTG, shoulder dystocia GTG, VBAC GTG, and these 3 nice guidelines are extremely important. Just have a look at when to deliver which twins, what to offer her during delivery, intrapartum care, preterm guideline, very important, preterm and preterm GTG also, and inducing labor, nice guideline. So if you will brush through these guidelines, your knowledge will again be freshened up and you will be ready to take up any case of management of delivery. So that was all regarding this management of delivery. Hope this video was helpful. Just keep on revising and all the best for your exams. Thank you.